All right, I think we can get started. This is evening time, I think, for many of us and morning for some of you. This is Lianne Gensler. I am a rheumatologist at UCSF in San Francisco, and I am here to moderate a very fun session as we wrap up from ACR Convergence 2022 with some outstanding reporters who have been at the meeting thinking about axial spondyloarthritis, and we're going to talk about that today. So first, perhaps let's just get started with introductions, and I'm going to hand it over to Sheila first. Sheila, please introduce yourself and then hand it over to someone else on our panel today.
Right. So good morning from where I am now. I'm Sheila Reyes. I'm a rheumatologist from the Philippines, and I've been virtually reporting for Rheum Now. So I'll toss the coin to Akhil.
Oh, hi. My name is Akhil. I'm a fellow at Stanford University. And I was at ACR on site, and I'll pass it over to Cassie.
Hey, good evening. My name is Cassie Sims. I am a rheumatologist at Duke University, and I was on site, but now I'm back in Durham, North Carolina, and I'm going to pass it off to Eric.
Hi, Eric Dein from New Jersey. Just arrived back from going back to my hometown of Philadelphia. So we'll finish it off with Antoni.
Hello, I'm Antoni Chan. I'm a rheumatologist from London, United Kingdom. Attended the ACR virtually. Glad to be here tonight.
Wonderful. And so really, actually, we have such a diversity of people to talk about these abstracts, both regionally, but also some of us were virtual and some of us were on site. And so really getting a flavor of abstracts in all their forms. So as we think about axial spondyloarthritis, it was an exciting meeting. There was lots out there. Perhaps I will ask Sheila first to share with us an abstract that really hit home for you, something that you were excited about hearing, and thoughts about how it will change your practice.
All right, so I'll go ahead. I chose. I really was interested with abstract 1673. So this was a study from the GR2 cohort from a French population. And so it was an observational perspective, multicentric study, which looked into factors that were associated with time to conception. So they defined time to conception as the time when a woman started actively to conceive or to stop contraception. And then they also looked into the proportion of patients who were subfertile, and to describe exposure to conventional DMARDs or biologics in the preconception period. So this was relatively a small sample size. It was only made up of 88 patients, where the average age was around early 30s. And so median time to conception was around 16 months. And the disease duration of the patients that were included were usually the median of 5 years. So patients were on those in the preconceptional period. They were on NSAIDs, they were on TNF inhibitors, and some were also on corticosteroids. Mm-hmm. And what the study showed was that women who were on NSAIDs had 2.6 times an increase or longer time to conception versus those who were not on NSAIDs. So the issue there was, for me, probably my take, what the reason why I also chose this abstract to share was, it reinforces, although this is an observational study, and of course we would hope that we get more robust data in the future, but this also reinforces the conditional recommendations that the ACR had in 2020 about considering stopping NSAIDs preconception. And it also makes us reconsider our prescribing practices of NSAIDs to our female AXPA patients, particularly since these patients are in their reproductive age. So we should also consider, on top of the probable side effects of our medications to our patients, but in terms of female patients, we also should consider fertility issues, and particularly when they have difficulty conceiving, probably we really need to look into other factors such as medications, and one of them is NSAIDs.
And tell me, Sheila, when you heard this presentation, you mentioned that actually some of the patients in this cohort were on biologics. So did they compare time to conception? Was it shorter if you were on a biologic compared to on an NSAID, or was it just compared to no drug?
Okay, they only compared it with the NSAIDs because they found that age and NSAIDs were negatively associated with the time to conception. So that was the significant result they had. Some of the other limitations also were that for NSAIDs, for example, they did not really go into like how long the patients were taking the NSAIDs or the dose of the NSAIDs.
Right.
And yeah, so there were still other data lacking, but I think it's a really good point where there could be future investigations in the area.
And did they measure disease activity? Because I think that's always, when you have observational studies with medications, how much of it is the drug versus the disease activity that the drug is controlling? Did they measure that at all?
Yeah, they did mention about the mean BASDAI, their disease activity during preconception, and it was about 2.88. So that was the result that they gave out. And I think just to add, there were also, because I was able to interview the presenter of the abstract, and also it was also asked in the abstract session as to whether how the NSAIDs could have been causing the longer time to preconception or the subfertility. And it's mainly because of its action on the prostaglandins, where prostaglandins also they are essential for both ovulation and embryo implantation. And we know that NSAIDs block prostaglandins, therefore they could affect they could lead to anovulation and poor implantation.
Yeah, I think that there's lots of important questions for us to ask here. Cassie, I know you're interested in women's health too. What do you recommend to your patients?
Yeah, so this is a really important topic because NSAIDs are such a commonly used medication. So I think the first point is that asking women about their pregnancy planning or fertility or personal goals is really important, especially because this is typically a younger population. And if we can limit the amount of NSAID use, it might prevent a more expensive and extensive workup for infertility. And we also don't want women trying for an entire year and not becoming pregnant. And then it's simply just because she uses excessive amounts of NSAIDs and it's preventing her ovulation and preventing her from becoming pregnant. So the data shows that women with ankylosing spondylitis have relatively successful pregnancies. TNF inhibitors are becoming a lot more comfortable using those during pregnancy, and even beyond certolizumab, other types of TNF inhibitors. So we have options. Really, the biggest issue we see is women who want to have a vaginal birth. Sometimes positioning is difficult for women with AS because of either fusion or inflammation. And so that's another thing we have to counsel patients on with physical therapy or working with our obstetrician. But I definitely think it's something worth asking. And, Dr. Gensler, if a woman wants to get pregnant and NSAIDs really seem to be the preventative issue, would you be more inclined to starting something like a TNF inhibitor if the disease was active enough?
Oh, for sure. I mean, I think that like if NSAIDs work to control the disease, I hate to throw the baby out with the bathwater. But if it is preventing, if fertility is being affected by it, then no question. I think it's an easy, you're NSAID sparing when you can get someone on a biologic. I counsel my patients. It's not very romantic, but I tell them to measure their LH surge. And really when it's around because you think about how short acting NSAIDs are, they're typically out of the system if you stop around the LH surge by the time implantation happens. And so I don't know, there's not a lot of evidence there, but there's mouse model data that suggests that it really does affect implantation in terms of where in the pathway to fertility. But yeah, absolutely. And then the other thing is sometimes patients stop themselves, and they would rather tolerate disease activity. Not that I think that's a great thing, but they would rather not be on anything. But I think what we're highlighting here is this is a shared decision, and we really need to know what is the patient's agenda, risk benefit, all of that stuff becomes different and important in the setting of thinking about pregnancy than I think when you just have a single patient thinking about themselves. Maybe let's go on to, so Cassie, I know you had you had sort of an abstract that you were interested in sharing about an individual patient sharing their own story. So maybe I'll keep with you and go to you next.
Yeah. So this is I guess it's abstract PP25. And this is the view of a medical doctor who was diagnosed with ankylosing spondylitis during medical school. He was 22. And when he initially received the diagnosis, he was in denial, and he turned to things like alternative medicine and physical therapy and exercise and orthotics. And he was started on a DMARD as well, but really had minimal relief from that medication. And he went on vacation, and he actually had to put his studies on hold because he was bedridden because he was in so much pain, and eventually found a doctor who understood his predicament and met him where he was at and helped him accept the diagnosis. And interestingly enough, he was put back on the exact same DMARD and did the exact same exercises, and his pain drastically improved. It was almost like the mental acceptance of the diagnosis itself made such a huge physical difference. And he likes to practice Tai Chi and yoga and swimming and table tennis as well when it comes to staying active. And his mantra is that on his good days, he doesn't like to overexert himself. And on bad days, he likes to strive to be as active as he can be. And so a lot of our patients, they struggle with anxiety and depression, and that worsens their disease and it worsens their comorbidities. And kind of bridging off of that, abstract 0387 looked at poor sleep quality in patients with psoriatic arthritis. And this found that 63% of patients reported that their sleep quality was poor, and that was associated with anxiety and depression. So all these factors are connected to each other. And I actually tweeted about this abstract on poor sleep quality, and a woman with psoriatic arthritis commented and said, "My doctors never ask me about this. All they ask me is how my disease is doing and if my medications are working." And I'm guilty of that. I mean, that's what we're interested in. We want to make sure their disease is well controlled, but patients may not think that their sleep quality or their happiness is relevant to their rheumatology visit if doctors don't initiate those conversations. And in this patient's case, this doctor with ankylosing spondylitis, I mean, his mindset, when it was changed and improved, his disease got better and he became happier and more functional. So I think we need to, as physicians, ask patients about their mental health and their sleep quality, because it plays a big role in how well they function overall.
I love that I feel like we are becoming more and more, as much as we have so many more tools in our toolbox from a pharmacologic standpoint, I'd like to believe that we're becoming more holistic about our approach to how we think about patient care, and that it isn't just, prescribing medication. You also said something that really hits home for me, and that's this patient physician that, the burden of disease. We first see a patient in clinic, we have limited time, we want to help them feel better, we want to treat their inflammation in their disease, and then having that conversation, what does that mean? What does it mean to you to now have this chronic arthritis that you're going to deal with the rest of your life? And that burden is enormous. And so I love when there is time to acknowledge that and really sort of have that conversation with patients, because we forget about that. I also, you said, the sleep issue. I had this experience when I was on a Delphi exercise with a patient research partner, and they asked the rheumatologists, "What do you care about for outcomes for patients?" And we care about disease activity. Mm-hmm. Patients don't care about disease activity. They care about pain. They care about, fatigue. They care about sleep. And so I think really acknowledging what is it that's bothering the patient. Sure, those components feed into disease activity, but it's really the symptoms that are bothersome to the patients, not the composite of disease activity. Thank you for sharing that. Let's go to Akhil. What did you find interesting at the meeting this year?
Yeah, so it's going along the components of, looking at the full picture, not just the disease activity, the specific rheumatologic condition, but abstract 1609, I thought was very interesting. It was a large population study using the SOAS cohort. They looked at the impact of comorbidities on disease activity and functional status in patients with ankylosing spondylitis. And I thought this was a really good study in that they looked at specifically how comorbidities affect these factors in patients with ankylosing spondylitis. And I thought the approach was really unique and really interesting in that they used a clustering approach to find presence and combination of certain comorbidities and how that interplays with these activity measures, including BASDAI and ASDAS, as well as functional impairment as well. And also looking at the other components, we look at swollen joints, tender joints, enthesitis. And using this clustering approach, they found that there were 5 unique clusters. One of the clusters was defined by the presence of uveitis. Another was defined by the presence of hypertension. And then another was defined by the presence of depression. And another was considered miscellaneous with a component of different comorbidities. And then the last was no comorbidities. And then the group that was no comorbidities was used as a reference group. And essentially what they found was that the group with depression had significantly higher disease activity as measured by ASDAS, BASDAI, as well as functional impairment, and then even when looking at the other clinical measures as well. And that this group really stood out as having just overall poor disease activity and functional impairment. And I think this is a really interesting study, and that it does pave the way for even more research, more investigation, is that one is the presence of depression, but also looking at the quality of depression as well, and seeing how that can really impact the measures that we look at is disease activity and functional status. And I think that does pave the way a lot. And then I think even going back to another presentation was when the ASAS EULAR recommendations for management of XPA. One thing that really stood out to me was where they mentioned that when the patient fails to respond to treatment, 1, consider alternative diagnosis, but 2, also consider the presence of comorbidities. And I think this abstract really stood out in that sense and really does pave the way for future direction to really look at comorbidities and how it interplays with management of not just disease activity, but just overall symptom control and symptom burden in patients with ankylosing spondylitis and axSpA.
Yeah, no, I totally, and I was part of both of those studies, but including the guidelines. And I think that's a new recommendation actually from EULAR to really consider whether there are other factors driving disease activity. So what do you all do in your clinic? Antoni, what do you do in your clinic as you're thinking about patients and how they comorbidities? Do you measure depression with a PHQ-9, or do you are you asking a review of systems?
Yeah, absolutely. I think it's really important to understand that it's not all about objective inflammatory measurements. CRP and MRI have their place, but often if the CRP and MRI are very low or even normal, patients still report pain and fatigue. And so we have to look at factors such as depression, independent sleep, function, the presence of fibromyalgia, because it may be that it's not a case of switching the biologic, but actually trying to deal with some of these issues through physical therapy, cognitive behavioral therapy, and the patient comes back feeling better, and we've saved them a switch to another drug.
Yeah, absolutely. Eric, what do you do?
Yeah, I think kind of coming back, merging that with what Cassie had said, a separate session that I thought was really helpful in this was the 2022 guidelines on integrative and non-pharmacological treatment, and that was for rheumatoid arthritis, but I think you'd be hard pressed to find something that doesn't apply to spondyloarthritis. That I think it's actually really useful that now you can point to all these things and say that there's actually guidelines behind it, even if some of it is expert opinion and not very much all that these things that may not be studied. But I think there's so much that goes into it, and trying to tackle 1 or 2 things in a visit, because you can't go through the list of everything, but really actually spending a couple extra minutes to get to the bottom of what's driving these things.
Yeah, I mean, I think these comorbidities are so intertwined, right? So like, can you really say that the depression is driving the disease activity when certainly disease activity pain is going to drive some depression? So I think though we are in a place, and the guidelines follow this, is like you treat the patient first, you treat their axial spondyloarthritis, but then once you've done what you can and you believe that you've really treated the inflammation and you're still left with residual disease activity, thinking about these other things. For sleep, Cassie, you talked about sleep in psoriatic arthritis, but I find, I don't know how many of you refer for sleep studies or to sleep medicine, I find so much sleep apnea as the driver for fatigue in our patients with spondyloarthritis especially. that, again, it's this holistic approach. Great. Well, Eric, what did you notice at the meeting this year that was exciting to you?
Yeah, so I really enjoyed the Ignite talks. I thought they were a very interesting format of getting some of the posters out. I think I would have liked to see more posters in person, but I think it was great to be able to have these presentations and go through some of them. And so I enjoyed one of the talks by Dr. Alexis Agdi, gave abstract 0402, which was on opioid use and healthcare utilization. And this was across psoriatic arthritis and ankylosing spondylitis. And what she found was, I think what wouldn't surprise a lot of us is that, about a quarter of the patients, was 27% of patients with ankylosing spondylitis were on opioids, and 21% of psoriatic arthritis were on opioids. But she said in her presentation, actually, what my hypothesis would have been, that I would have thought these are patients that are using it as a Band-Aid instead of being on DMARDs and not using as much of the disease-modifying treatments because they're masking it with opioids. And what they found was actually the opposite, and that there was no statistical difference, and maybe even a trend that patients were who were opioid users were actually accessing medical care more. They were seeing rheumatologists, they were having more medical visits, more medical tests, more healthcare utilization and costs. And actually they were on at least and often more disease modifying drugs than patients who were not on opioids. The opioid users were, I think, not as surprisingly, they had more comorbid diseases, they were smokers, and they had worse disease. But I think it is interesting as we think of it, these patients with opioids, which of course really should not be used as treating the AS, as a disease modifying agent at all, because it's not. But they're not necessarily accessing it to replace it. It's that they're often a sicker group of patients that are having more struggles to get it under control. So I think it's just showing that when you see a patient who has such severe pain, it's something that should raise our flags, and we really need to understand this group of patients more and understand what it is about them that's driving them to be on these, very harmful medications.
Yeah, I mean, I think some other studies have shown in opioid users with axial spondyloarthritis and AS specifically that there is less biologic use. And if you look at claims data, like a fraction of AS patients are actually being prescribed biologics compared to other inflammatory arthritides. I wonder, is this like a US problem? We're very lucky to have both Antoni and Sheila here. Tell us, do you see the same problem in your countries?
Okay, I'll go first, Lianne.
Yeah.
So, well, in terms of opioid prescriptions and giving of these medications to our patients, I don't really have the exact numbers, but I think it's safe to say that we do prescribe it less here in this part of the world, in our country. And again, with what Eric was saying about the results of the study, we always come back to the question of whether maybe these patients, we're not really treating what these patients have, or we look at other factors like again the comorbidities, their inability to sleep, and all those things. And so Dr. Agdi gave a very good lecture on treat to target strategies and identifying the targets. And I think we really need to talk to our patients as doctors. So going back to the opioid use, I couldn't really give enough data, but from in general, from our practice, at least in my practice, I don't really give it much.
Mm-hmm.
If there is really any need, it's not particularly for the spondyloarthritis, but other comorbid conditions.
Right. How about you, Antoni?
Our treatments for axial spondyloarthritis has improved so much that our use of analgesics have gone down. Yeah. Because we can now target and we treat them very early now with biologics, and that has really reduced the opiate use. And we feel that a lot of these patients, we actually were masking their symptoms for many years by taking opiates. and they end up having very stiff and sort of damaged spines. So we have completely changed that, and we are moving more towards non-pharmacological therapies for these patients. So physical therapy or cognitive
Some
behavioral therapy.
Yeah.
Just to try to deal with some of these other issues like pain and fatigue, and we find that quite a useful strategy.
Sounds like we've come full circle to the exercise being away from opioids towards exercise and a holistic approach as we think about disease and comorbidities. Wonderful. And Antoni, you are last obviously attending the conference virtually. So was it a challenge for you, first of all, to?
No, it was I found it quite nice to be able to attend virtually. And in fact, the most of the sessions were very accessible. Of course, some of the sessions were not streamed live, but you could watch them 24 hours later. So I managed to catch up with the time zone. It actually works to my benefit.
Right. You didn't have to watch in the middle of the night.
Correct.
So what did you see the meeting that was exciting to you?
So I was very interested in looking at new modes of action in XBAR. So the IL-17AF dual inhibition data was presented as a late breaking abstract L14. And this is the 52-week data on bimekizumab. And it come on the back of two other presentations, 411, which is the B-Mobile 2, which is the AS data, and 544, which is B-Mobile 1, which is non-radiographic. Those two were the 24-week data, but this late-breaking abstract was 52-week. And it was very interesting to see that the ASUS40 was 60%, and the SDAS less than 2.1, the low disease activity, was also about 60% in both groups. So this is quite a good data that we have. And the inactive disease SDAS less than 1.3 was 25%. So clearly a very effective new mode of action. And we've always been very concerned about candidal infections with IL-17A. We didn't see it too much with IL-17A, but with dual inhibition, what we wanted to know is after 52 weeks, were we seeing more candida infections? There was about 20% of these patients who had fungal infections, but none of them required stopping the treatment. In fact, from the whole study, there was only 2 in the AS and 2 in the non-radiographic that had to stop treatment. So that's, again, quite a nice reassuring safety signal that we're not seeing too many systemic or candidal infections requiring stopping of treatment.
And so you said something that I think we all as rheumatologists, we hear and we shudder, and that's fungal, right? So we don't want our patients, and we know this from the TNF inhibitors, if you're, depending on what side of the Mississippi you live in, or where in California or Arizona you are. So, but these are, they're, yes, Candida, classified under fungal infections, but they're different. And what we're not seeing, I think, reassuringly, is true fungal infections or systemic, even candidal infections. So that does feel good. I think, it is a new mode of action. 52 weeks is what we needed, longer than primary endpoint data to really understand side effects better, but I still think we need more data. We, fortunately, I think for like safety and these kinds of AEs of special interest, you can look at other disease states to get a whiff of what might be coming. So there's lots of long-term data in psoriasis, obviously, because psoriasis gets studied before anything else in spondyloarthritis. And I think candidal infections, typically mild to moderate, not severe, are more common when you inhibit both A and F compared to F alone. But so far, I agree, it's reassuring, and I think we need longer term data. And what I loved about these, there were multiple bimekizumab trials, both in psoriatic arthritis and in axial spondyloarthritis. What was really remarkable is that actually in the axial spondyloarthritis trials, these were parallel trials in radiographic disease and non-radiographic disease. The response was the same, regardless whether it was non-radiographic or radiographic. And very interestingly, the numbers were small, but a portion of the patients were TNF and adequate responders. And they did well, better than, in fact, the same compared to the bio-naive population. Now, it wasn't powered to compare those, and so we have to be careful because the numbers are small. But it is really nice to see a group of patients that have been inadequate responders to another biologic do as well as a bio-naive population. But I think we need even longer term data to know whether this is going to not just be as safe, but more efficacious. We don't have any head-to-head data, right? For bimekizumab in psoriasis, we have head-to-head data against another IL-17A inhibitor. You would probably remember that from last year from NEJM, but whether that translates to arthritis outcomes, I think we still need more, and always head-to-head if possible. Wonderful. Are you going to be looking to using these MOAs, novel mechanisms? Who's itching to use a new drug? I mean, do you feel tapped out for axial spondyloarthritis? Maybe Eric, I'll ask you first.
I think it's, we've got a toolbox that keeps growing, and I can't wait until we can run the perfect test that tells us which is the drug for each person, because I think it's great that we're having all these options, and it's great that we can continue to find better drugs, but it's getting hard to choose which one for which person.
Yeah, precision medicine. I know. Obviously, I speak a lot and teach about spondyloarthritis. It's been relatively easy because there's not that many choices. So it would be nice to have more choices, but I think the critical question, as you brought up, is not so much more choices, but which one to go for first for the individual patient. How about others?
Yeah, I'm definitely looking forward to putting some of my patients, especially now that we know that it works even with TNF inadequate responders. So they might be the ones we go for first because they've tried 1 or 2 biologics. And it certainly looks promising from the data that we have to 52 weeks.
Yep, definitely. We'll see where it lands in our algorithm and with our payers, right? At least in the US, it won't be up to us to decide. Sheila, will you have access to these kinds of MOAs?
Okay, so I was going to say that not yet, but hopefully in the future. Right now we still have limited. We're all only what's available here are the TNF inhibitors, but not all. And so we're really looking forward because we know that there are data that biologics work, but then here another issue would be the cost of these treatments to our patients. I mean, they may be available, but not all our patients can afford them. So there are still lots of issues. But yes, we're really hoping that we could give better treatments for our patients, and so that they can have better quality of life, better treatment outcomes.
Yeah, wonderful. Well, this has been a really fun discussion and session to talk about impactful abstracts from the ACR 2022 meeting. Thank you all for, of course, thinking about spondyloarthritis this meeting and bringing your favorite abstracts to this session. All right. And then next year, hopefully we'll be back. Any last comments or thoughts from anyone in the group?
It was great to be back in person. It was good to see everyone.
It was great to be back in person. I look forward to more in-person meetings. It's so nourishing for sure. And then to Antoni and Sheila, I'm glad you were able to get, of course, science out of the meeting. We look forward to running into you in person.
We hope to see you in San Diego.
Yes, we hope to see you in San Diego. Yeah.
Wonderful. All right, everyone, have a great rest of your day and happy holidays, and we'll see you in 2023. This is Lianne Gensler for Room Now. Thanks, everyone.